Great. Welcome, everyone. So our first speaker today is Dr. Mehta, who's based down at Denver Health, or excuse me, at National Jewish, the Division of Pulmonary Sciences and Critical Care Medicine. Dr. Mehta has only been in Colorado about 6 months. Prior to that, he did his MD at Cornell, followed by residency and internship at New York Presbyterian, and fellowship at BU, followed by advanced fellowship at BU as well. But as I said, just came about 6 months ago to take a position here as an instructor. His main interest is outcomes and focusing on primary care issues. He's had a number of interesting projects. The one he'll be focusing on today is actually the focus of a K23 application that he's preparing as part of the research program that he's launching. It's a number of publications in multiple areas related to outcomes in critical care, and has been very busy in the past 6 months settling in and is enjoying it so far. So thank you for being here today.
Thank you, everyone. Having shown up just 6 months ago, it's a great opportunity to sit here, stand in front of you, talk about some of the areas of interest, and try and get to meet some folks out here. When we're over at National Jewish, sometimes we exist in a little bit of a silo, so hopefully this will help build some more bridges. Again, my name's Mehta. I started 6 months ago. My areas of research are mostly in health services research, delivery of care, and with some changes based on some of the data that I've developed. So the title of my talk is Tracheostomy Utilization and Outcomes in the United States. Just by way of some background, because I know a lot of people have some different backgrounds here, research, clinical work. Mechanical ventilation is one of the cornerstones of intensive care medicine. And patients often end up on invasive mechanical ventilation for respiratory failure, from everything from trauma to pneumonia, and I'm sure there have been a lot of talks about kind of the basic biology of ARDS and pneumonia and things like that. This is a picture of the most common way that we ventilate people, which is with an endotracheal tube. It's a tube in the mouth, and it is uncomfortable for a lot of patients. They require a lot of medications for sedation, and there's a lot of complications that arise over time, especially after the first 14 days, specifically mouth ulcers, injury to the trachea, injury to the vocal cords, and these can be life-altering complications should a patient survive the mechanical ventilation. So depending on where you are, when you start getting to that 1 to 2 week mark of being on a ventilator, being on life support when you're not able to really breathe on your own, people start to think about something called a tracheostomy. And a tracheostomy is used to facilitate prolonged mechanical ventilation for the majority of its use. And as you can see here, the tube has been moved from the mouth to a hole in the throat. And, on the surface, that looks like a minimal change, kind of moving a tube from the mouth to the throat. But it can have a lot of long-term implications. It's a marker of chronicity of illness for sure, because if you think somebody's going to come off the machine pretty quickly, you're not going to do the surgical procedure. So patients that get the tracheostomy tend to require the life support for their lungs for a prolonged period of time. Why is this beneficial over endotracheal tube? Well, it's theoretically more comfortable for the patient, even though it's a surgical procedure. It's below the vocal cord, so it's not inducing that gag reflex that a lot of patients have with the tube in their mouth. So they don't need as much sedation medication. There's a lower risk of injury to the vocal cords, and there are a lot of other benefits potentially for work of breathing issues as well. So this is considered kind of at that 1 to 2 week mark to facilitate the prolonged mechanical ventilation. But there's a lot of, not concern, but there's a lot of questions that are raised with tracheostomy utilization in the United States. So there are studies that suggest there's significant short and long-term morbidity and mortality for patients that have a tracheostomy. And partially, it's a marker of their severity of illness. So it's not surprising that these patients have a lot of complications moving forward because they're on prolonged life support. It's also a significant stress for both patients and their caregivers. The decision is most often made by surrogates, not the patients themselves, because they're have the endotracheal tube in, they're sedated, they can't participate in that decision-making process, so it falls to their loved ones. So the decision itself and then the long-term care that follows offers a lot of stress to both the patients and the caregivers. It's a huge cost. Prolonged mechanical ventilation has significant cost and resource utilization implications. It contributes disproportionately to the $263 billion spent annually on the critically ill patient. There's recurrent hospitalizations that require the ICU. These patients tend to be in long-term care facilities for a prolonged period of time. And there are some suggestions that they are repeatedly hospitalized in the acute care setting, which is, again, stressful for the patients and their caregivers, but also has implications based on hospital readmission being a hospital quality marker with financial implications for Medicare reimbursement. And there's growing literature questioning whether tracheostomy actually aligns with patient wishes, whether 6 months after the fact patients would say that they would have done it again, or whether the decision that was made by loved ones really is consistent with what the patients would have otherwise wanted. And there was a paper that came out of Pittsburgh recently that described a feeling that a lot of patients express that there are many states worse than death. So while a tracheostomy can be a life-prolonging measure, it may not be consistent with the other goals of care that patients and surrogates really want. And one of the other big questions that exists about tracheostomy, if you can imagine the course of mechanical ventilation, you get intubated on day 0, intubated with the endotracheal tube in the mouth. When do you do the trach? At what point do you say the risks of that tube in the mouth warrants a surgical procedure with a tube in the throat? And so some people have looked into whether doing it in the first week of mechanical ventilation to improve comfort, second week of mechanical ventilation, or even later. So there have been a few big clinical trials, and there's no clear mortality benefit from doing an earlier tracheostomy. And some data that I'll present also will suggest potentially that maybe there are some harms associated with early tracheostomy. So there are a number of research questions that came to me based on some of the studies that have already existed. How has tracheostomy utilization changed in the United States? With an aging population where mechanical ventilation is more likely to happen, if this is increasing as mechanical ventilation has been increasing, the cost implications are huge. How have the outcomes have changed? Are we doing better with patients that end up with a tracheostomy? Do we know how they're doing? How can we advise patients and their families on these outcomes? Is there institutional variation? You know, there's certain standards of care that we strive towards. Tracheostomy is a little bit of a fuzzy area. When you do it, who's the best patient to do it in? So how do these practices vary by institution? And if you have the same patient who's admitted to 2 different hospitals, you know, will they receive different care based on prolonged mechanical ventilation? How has tracheostomy timing changed in the U.S., and how has it evolved? And those are 2 separate things that I'll try and address. Health services research encompasses a lot of different types of methodology, and if I went through the individual methodology for all of the individual studies I'm going to talk about, we'd be here talking about statistics for a while, which I think would probably bore most people. Just in sum, what I tend to do for these studies, I use large administrative discharge databases. So these are databases either compiled by individual states or by the federal government, by an organization called Healthcare Cost and Utilization Project. It's an arm of the Agency for Healthcare Research and Quality, AHRQ. And these databases can contain millions of patients per year, but they're not granular. They don't have vital signs, they don't have labs, but they have diagnosis codes, they have outcomes, they have patient demographics, and there's a lot of methodology that you can employ to try and figure out, try and answer questions that may not be answerable in a randomized clinical trial setting. I focus on adult patients. The indications for tracheostomy in children, very different. We identify our procedures of interest, mechanical ventilation and tracheostomy using billing codes that have been validated that are present in these databases. We identify disease cohorts like pneumonia, COPD, and heart failure utilizing validated billing code algorithms. So if you have a diagnosis of COPD or a diagnosis of acute respiratory failure and a diagnosis of COPD, we call that patient as having COPD. And these have been validated in prior studies. And we use a variety of statistical methods to try and try and compare outcomes, perform trend analysis, and determine risk factors for certain outcomes. And I'll mention some of the databases we use as I go through some of my studies. So one of the first things that I did looking at tracheostomy is kind of asking the question of how has it changed the United States over time, both in terms of raw numbers, in terms of age adjusted, just because we're having an aging population, is that why we're increasing the number of tracheostomies? And then as a percentage of mechanical ventilation. And that has a lot of cost and utilization implications. So this is a period from 1993 to 2012. The data is from the National Inpatient Sample, so it's one of the databases I use, has about information on 5 to 8 million patients per year, and is nationally representative. So this gives you a snapshot of what's happening throughout the United States. For you on the left axis, that's cases of tracheostomy per 100,000 U.S. adults, age adjusted. On the right axis, that's as a percentage of mechanical ventilation patients, and then the years on the y-axis. The blue line is the population-adjusted incidence per 100,000, and the black line is the percentage of mechanical ventilation patients. And you see a pretty significant trend towards increasing utilization over the course of time. You see a little bit of dip around 2011. We've extended this for another 2 years, and the numbers actually go back up. So it's kind of a fluke that you see that dip in 2011. So you're seeing almost a doubling in the incidence of tracheostomy. The raw numbers show an actual doubling, which again has huge cost implications. And it's not just that we're intubating patients more. It's not just that people are ending up with a tube in their throat more often. The growth in tracheostomy has outpaced the growth in mechanical ventilation during this time frame. And that has some important implications that I'll talk about in a little bit. We also break it down versus surgical and non-surgical patients, and the trends are really different. So the left axis is the percent of mechanically ventilated patients. The top line with the diamonds is surgical patients, and the bottom line with the triangles is non-surgical patients. And we can see that it's really surgical patients that are driving a lot of the increases in tracheostomy in terms of percent of mechanically ventilated patients. The raw number is increasing in both groups, but as a percentage of mechanically ventilated patients, it's increasing across the board. So one of the questions that we asked is if we're changing utilization, are the patients themselves changing? So the mean age for a patient receiving tracheostomy, this was surprising to us. We assumed that the patients were getting older. This was actually very surprising, that the patients are actually, from a mean age perspective, getting younger over time. Now, there are a lot of potential reasons for this. Are there more comorbidities earlier on? Are younger patients sicker? Are we more aggressive with younger patients? Has that been shifted over time? Are older patients, do they have more advanced directives like DNR that would preclude a tracheostomy? So a lot of reasons, but this was an interesting finding that a lot of the research that has been done in tracheostomy has actually been using Medicare databases, which is 65 and older. So if the mean age is under 65, it raises some question about the generalizability of some of those results. We see a shift in the demographics, and this is a little bit complicated, but the top line is white patients, and the black line is, the blue line on the bottom is black patients. So patients that receive tracheostomy are predominantly white, but we've seen a dip and then a little bit more of a rise in more recent years, and there's been a steady increase in tracheostomy among black patients. So that leads to some socioeconomic cultural differences in how tracheostomy is utilized. This graph, I think, is actually really important, and it doesn't look like there is a significant trend in these lines, but the top line is Medicare, and the bottom line is Medicaid. So this is showing that what's the primary insurance of the patients getting tracheostomy. And there's a steady decrease in the black line by about 5 percentage points over this period. There's an increase by about 5 percentage points in Medicaid. And that's really important because that represents a significant shift in the payment structure from federal governments to state governments. And not to get into a whole discussion about the Affordable Care Act, but if the states are paying for it and there's differential implementation of the Affordable Care Act, that actually has a lot of implications for where tracheostomy payments will be covered based on state. So this has a lot of healthcare utilization implications. So what did we see in terms of changes in tracheostomy timing? And again, I divided this based on surgical and non-surgical patients. And the black line is the percentage of patients that received a trach in the first week. The red line is the percentage of patients that received a tracheostomy in the second week. And the blue line is anyone that received it from the third week on. And what you see is a big drops in both graphs in the percentage of patients receiving it after the third week. And really, for surgical patients, it's a shift to patients being trached early within the first week or the second week. And for non-surgical patients, your pneumonia patient, these are patients that are receiving a tracheostomy during the second week. So this has some implications when I talk a little bit more about tracheostomy timing. We'll talk about why this is important. And then just in terms of some outcomes, there's been a steady decrease in length of stay for patients that are receiving tracheostomy. It's been cut almost in half from about 42 days to 24 days on average. These are for survivors of tracheostomy, people that survive to discharge. So patients are getting trached early, and that's been associated with a shorter length of stay. So what's happening at the end of the hospitalization? So this was something that an editorial on an article we wrote for the Blue Journal commented on significantly, is that on the left axis, it's the discharge destination as a percentage of total discharges for tracheostomy patients. And this is what I think a lot of people intuitively thought. The black line is the percentage of patients that died. We've seen a significant drop in mortality. The red line is the people that go home. So there's been a steady drop in the number of people that can go home after a tracheostomy from the hospitalization. The blue line is the percentage of patients going to a long-term care facility. And so over 70% of patients, of all patients that are getting a tracheostomy, end up in some sort of long-term care facility. So one of the questions that this raised is, okay, we're doing tracheostomies earlier in the course of mechanical ventilation. They have a shorter length of stay, but they're all going to some sort of long-term care facility. So are we shifting the burden of care from the acute hospital to the long-term care hospital? Does that result in more readmissions? Are they getting as good care? Or is there pressure to trach earlier to get people out of the hospital? So these outcomes raise and also the question is, if we're doubling the number of patients going to long-term care facilities, how are we actually paying for it? Long-term care insurance and payment for long-term care facilities is a big question, depending on the type of insurance you have. So this has a lot of cost implications moving forward. So based on this, we wanted to investigate some of the tracheostomy timing questions a little bit further, because we felt that there was a growing body of literature suggesting that doing tracheostomy early in the course of mechanical ventilation was not necessarily beneficial. So we looked in to see how much variation there was in early tracheostomy practices. We used we looked at the most common surgical reason for tracheostomy, which was trauma, and the most common non-surgical reason, which is pneumonia and sepsis. And what we found was wide variation. Nearly half, despite no benefits that we can see, nearly half of the patients, trauma patients, were getting trached early, and this was not for head and neck trauma. And nearly 1 out of 4 medical patients, non-surgical patients with pneumonia and sepsis, was getting trached within the first week. And again, like I've said, there's a growing body of literature suggesting that there's no actual benefit, but that early trach may help facilitate discharge out of the hospital. When we looked at outcomes, what we found was that there was a significant shorter length of stay associated with early tracheostomy. Not surprising, because it helps facilitate discharge. You can't leave the hospital with a tube in your mouth, but you can leave the hospital with a tube in your neck. Hospital mortality, there was no difference, as has been supported by previous studies. We did find a slight increased likelihood among pneumonia patients being discharged home, and a slight decreased need for a surgical feeding tube. These numbers, especially the discharge home, are so low. And when you use these large databases with millions of patients, you find a lot of statistical things that may not be clinically significant. But in general, we didn't feel that there was a lot of significant benefits to early tracheostomy. And when we look to see, do hospitals that perform more early tracheostomies, are they more likely to trach? If you as the patient go to a hospital that tends to perform more early tracheostomies, are you more likely to get a trach at any point during your course of mechanical ventilation? And for trauma patients, we found a modest correlation. And what that essentially means is that, well, for trauma patients, if you go to, regardless of any of your patient-level factors, if you go to a hospital that's more likely to perform a tracheostomy within the first week, you're more likely to get a trach in general, as opposed to if you go to a hospital that doesn't perform a lot of early tracheostomies, there's a better chance, if we watch and wait, of you coming off the ventilator. And what a lot of studies have shown is that people, when you wait till the second week, a large proportion of patients actually will come off the machine, and that we as physicians are poorly predict who's actually going to be on a machine for 2 or 3 weeks. We didn't find a similar relationship to pneumonia and sepsis. Just in the interest of time, I'm going to skip over this. So what are the implications from this, and where am I going to go from this moving forward? So we've seen large increases in tracheostomy utilization in an aging population. I think it portends significant increases in costs of long-term care in the United States that will need to be addressed. Granted, there's a lot of things in health insurance that needs to be addressed right now. Shifts in the demographics of patients receiving tracheostomy suggest shifts in the payment structure. We've demonstrated significant institutional variation, which suggests room for quality improvement. If one hospital is behaving very differently than another, understanding the factors that are associated with best practices, whatever those may be related to tracheostomy, may be areas for quality improvement. And the shift in the outcomes with earlier trach, shorter length of stay, and increased discharge to LTAC raises several questions. Have long-term outcomes really changed? Are there pressures to do tracheostomy early to facilitate discharge as a cost-saving measure for the hospital? And then do shift towards early tracheostomies, are they resulting in unnecessary tracheostomy? And is this really are we really performing patient-centered care? So I've talked a lot about big data and stuff like that. So what's the patient perspective of all of this? So as I stated, tracheostomy may be a life-sustaining intervention, but some patients view many states as worse than death. Are there other outcomes that we should be looking at in our clinical studies that are truly patient-centered? Only a small percentage of patients feel as if they are properly informed about what to expect prior to tracheostomy. And by patient, I mean patient or surrogate who makes the decision. And this is true across the ICU, is that there's a general sense that informed consent, they're not really feeling informed. There's reasonable evidence that patient expectations at the time of a tracheostomy about what to expect long-term don't align with physician predictions. And this discord contributes to significant patient and surrogate suffering long-term, and potentially care that's not consistent with patient values. So how do we take the big data and combine it with patient values? So the goal for hopefully my next 5 years will be building a decision aid for prolonged mechanical ventilation. There are a couple out there right now, and there's some limitations to their use. And so what the general principle in developing a decision aid is to take patient-centered outcomes, to define those in some way, shape, or form. As I said, mortality may not be a patient-centered outcome. Readmission may not be a patient-centered outcome, although those are the two things Medicare measures. How do we understand patient values and themes around prolonged mechanical ventilation, prolonged organ support, and how do we incorporate patient experiences into this process? But it's not all about the patient. Understanding what's going to happen long-term and understanding the medicine behind that is equally critical. So how do we incorporate medical team experience? How do we predict long-term mortality and readmission? And then how do we predict patient-centered outcomes? And putting all this together would help us build an appropriate decision tool to aid in a shared decision-making process. So the future studies that I propose to build a decision aid. So one of my main future studies that I'm hoping to launch in the next year is to perform in-depth surrogate interviews, to identify patients for whom tracheostomy is actually being considered. Our primary sites will be St. Joseph and National Jewish, and potentially here at the university, St. Joseph Denver Health, potentially here at the university. And this will take surrogates around the time of they're deciding about tracheostomy and perform semi-structured interviews. And this is to try and elicit common themes between all surrogates on what informs the decisions that they're making. What are things that they're interested in? Is it functional status? Is it whether they live or die? What are factors that are associated with that? And then also, what are the common narratives that these patients are making? And that'll be a key tool in developing a decision aid. The next step will be building a predictive model for mortality and readmission. So I've demonstrated a lot of epidemiology. The real question, though, is if you're my patient or I'm taking care of your loved one, the question you're going to ask me is, what are the chances of my loved one surviving? What are the chances of them being alive in 1 year? What are the chances of them going back to the hospital? And as of yet, we don't have a great predictive model. Some people have tried to develop it out of cohorts of 100 patients and things like that. But I propose using a fairly novel database out of California that allows us to track long-term admissions over the course of 4 years, track vital statistics after hospital discharge to build a predictive model to predict short and long-term mortality and readmission. And it has database has some very interesting variables that I think are fairly patient-centered in terms of how we will try and extract some of this information. The next question, though, as I said, mortality and readmission may not be a patient-centered outcome. So there's no data on weaning success. There's minimal data on weaning success in recent years and by weaning, I mean, what are the chances of you coming off the machine? There's little data on what's your functional status using a large population as opposed to, 50 patients, which is typically the size of the studies. What are the chances of you being able to talk with the machine, with the tube in your throat? What are the chances of you being able to eat? Which I hypothesize are really patient-centered outcomes. So I'm actually partnering with Kindred Hospital. Kindred is a nationwide long-term acute care hospital, and we are going to build a novel database that incorporates kind of patient-level factors, lab values, vital signs, ventilator settings, but also being able to track some of these more patient-centered outcomes to build a predictive model for those things that I think are more important to patients and their surrogates. And we will use these two predictive models plus what we gain from the interviews with our surrogates to try and build a decision aid. And then once we have that, we're going to try and pilot it here in Denver to try and really improve the decision-making process, which specifically for mechanical ventilation is felt to be very deficient. So I just like to, in my 6 months here, there's a lot of people to thank, which is always a good thing because that means a lot of people are willing to help. Ivor Douglas, Mark Moss, Megan Morris, Daniel Matlock here over at National Jewish, Irina Petrache, and Doug Everett at Kindred Hospital as well, and then Boston University and University of Michigan. I highlight Ivor, Douglas, and Alan Walkie. Alan Walkie was my mentor over at BU. Ivor is my mentor here, and they've really kind of helped codify what my plan is for the next 5 years. So thank you very much for your time. I'm open to any questions. Yeah, so that's actually a great point. So my research thus far has been in administrative databases. So that's actually one limitation is that I've been looking at big data and the patient perspective has really been lost. All of the comments on patient perspective are actually from other people's work. So my goal is to actually perform in-depth patient and surrogate interviews to do a needs assessment for what types of information do they need to make the decisions, and then use these predictive models to try and present that information to them in a coherent manner that's usable. That's a great question. Thank you. Just a little bit of background. You put the tube in the throat. Eventually, hopefully, you come off the machine. And then there's also the step of taking the tube out. Hopefully, when you're off the machine, the tube comes out pretty quickly thereafter. Using the Kindred, and this rarely ever happens in the hospital. this can sometimes happen more in the long-term facilities. And so partnering with Kindred, they have a lot of hospitals throughout the country, and they do have data on weaning success. So weaning is the process by which you slowly turn down the breathing machine and hopefully get somebody off the breathing machine, which would facilitate having the tube come out. We're going to look at some institutional variation. The bias here is that it's all Kindred hospitals, and there's very little data on whether or not somebody's discharged from a long-term care facility still with a trach in any sort of other large administration. Even the Medicare database that is attached to LTAC doesn't have that. So we're left with partnering with a private organization to do the study. But I think even that, whether it's regional variation, whether there's specific patient factors that'll predict it. So we'll start with using the Denver cohort, but we'll have access to a nationwide database with multiple institutions. So we'll hopefully be able to try and address what will facilitate people coming off the machine, and then how can we protocolize that process. Oh, thank you.